So I'd like to cover several things this morning in this presentation. First, I'd like to start off with a practical way to think about a patient who presents to your office with a lump in their neck and how to think about it in a way that makes it a little bit simpler than considering every single diagnostic possibility for a neck mass in every patient. Once we have that approach, we do have to develop a good differential diagnosis like you do for everything in medicine. And then fortunately, we have a recent clinical practice guideline from our academy that was just released in September that we'll review. And finally, I'd like to talk about human papillomavirus, or HPV, and its relationship to head and neck cancer. Time allowing, I'm going to throw in some cases at the end that we'll all be able to quickly develop a differential diagnosis for after the presentation. So as a definition, a neck mass is any abnormal lesion which is visible, palpable, or seen on imaging. In coming up with this approach here, which is sort of the nuts and bolts of the whole talk, it's almost hard to synthesize for a lecture how you think when you see somebody in the office with a lump in their neck. But even if you're not thinking about it, your brain has to do this in some way. And if you look at literature, you often see papers that are neck mass in children, neck mass in adults, or papers that exhaustively list the differential diagnosis for a neck mass. And none of those are practical because it's a little bit overwhelming to think about so many things for every patient. So, but narrowing it down, you can think anatomically, where is the neck mass located, or you can think about a neck mass relative to the patient's age and develop a differential diagnosis. What I personally do and would recommend is a little bit of a synthesis of the two, in that children and adults, generally speaking, can have the same diagnoses. However, the frequency of diagnoses are very different for children and adults. In children, you're going to have a much higher probability of a benign etiology for a neck mass, whereas in an adult, there's a much greater probability of cancer. But of course, adults have inflammatory conditions, and children can have cancers. The way I'll present this talk and the way I think about it is we break down the head and neck area into different regions, because the differential diagnosis is different based on each region of where the neck mass is located, and that allows you to at least develop a more specific differential diagnosis rather than some comprehensive differential for every single neck mass. Broadly speaking, we think about the cheek and the cheek area, the area from the chin to the sternum, the lateral neck, the supraclavicular fossa, which is a special area of the lateral neck, and then the back of the neck. Just like any other part of the body, your differential diagnosis for a lump can include infectious causes, inflammatory causes, which are not infections, congenital etiology, and tumors. Tumors, of course, can be benign or malignant. Starting with the cheek subunit or cheek area of the head and neck, the structure that dominates this area is the parotid gland, which occupies much of the posterior aspect of the cheek. But of course, the mass can arise from either the skin or the subcutaneous structures of the skin, as well as lymph nodes. Sometimes people forget there are lymph nodes in the cheek, both superficial to the parotid gland as well as within the parotid gland itself. Beginning the differential diagnosis for a mass in the cheek, we have a picture on the right of a congenital vascular mass. Vascular tumors and malformations include hemangiomas, which are true tumors, as well as lymphatic and venous malformations. And in the area of the cheek, the first branchial cleft cyst can present as a small mass in the cheek, usually in a child or a young adult. Moving on to inflammatory causes, the skin and the ear canal are a frequent cause of inflammatory enlargement of lymph nodes in the preauricular and postauricular areas. Think about acne. It's actually a fairly frequent cause of lymphadenitis in the head and neck area. Inflammation, obstruction, infection of the parotid gland will present as a lump, usually of acute onset, and we have tumors. A mass in the posterior cheek is most likely to be a tumor originating in the parotid gland. Fortunately, most of these are benign, but there are significant parotid cancers as well. Parotid cancer, most of the time, is a primary parotid neoplasm, but because the parotid gland includes about 3 to 5 lymph nodes, you can have metastatic cancer into the parotid gland, usually from cancers of the skin, the ear canal, and the temple. So when someone has a lump that you suspect to be in the parotid gland, you want to take a history looking for cancers that they may have had in the last year or so on the ear or in the skin of the cheek. Anatomy of I call it the midline area. Again, this is from the chin to the sternum. You can have masses arising, again, from the skin and subcutaneous tissues, the strap muscles, the larynx itself, meaning the cartilages of the larynx, as well as the thyroid gland in the lower neck. The differential diagnosis for a mass in this vertical area includes congenital masses, both dermoids as well as thyroglossal duct cysts. Inflammatory cause, especially when a patient presents with a lump in the submental area, meaning the soft tissues just under the chin. Think about acne on their chin. It's actually a very common cause. And you have dental causes. Patients have a painful tooth, especially on the mandible. They may have an infected lymph node from that. Thyroiditis, which is an inflammatory condition of the thyroid gland, will present as a tender enlargement of the thyroid. Moving on to neoplastic disease, this is going to be mostly the thyroid. As you all know, most thyroid tumors are benign, with a small fraction being malignant. In the lymph nodes under the chin, above the larynx, metastatic cancer from the oral cavity, including the lips, the oral tongue, and the floor of mouth, can metastasize to this area. And other tumors in this area are quite rare. These would be mesenchymal tumors arising from the connective tissue elements of the muscles, nerves, cartilages, and bones of the anterior neck. Moving on to the anatomy of the lateral neck, the sternocleidomastoid muscle has been removed for this drawing, but that's the biggest structure in the lateral neck. Deep to the sternocleidomastoid, we have the carotid sheath, which includes the carotid artery and the internal jugular vein, as well as the vagus nerve. And we have lymph nodes, which course along the internal jugular vein. And at the top of the lateral neck, in this area here, the submandibular gland has been removed, but this is under the mandible. And sometimes it can be hard to distinguish a mass right at the angle of the mandible from something maybe arising in the parotid just above here or the posterior aspect of the submandibular gland. Moving on to the differential diagnosis for a lateral neck mass, again, we have vascular malformations and hemangiomas in a young child. Again, children and young adults, it certainly could be a branchial cleft cyst, with the second branchial cleft cyst being far and away the most common branchial cleft cyst. Third branchial cleft cysts are quite rare. The second branchial cleft cyst will be higher in the neck than the third typically. Inflammatory causes for a mass in the lateral neck are certainly the most common reason for a patient to have a lump in this area. Viral illnesses will often cause mild enlargement of the cervical lymph nodes. But of course, bacterial lymphadenitis is possible, including cat scratch disease, as well as atypical mycobacteria. I throw one other entity up here, this carotidynia. If you haven't seen it, you should be aware that there is a condition called carotidynia, which is not terribly well understood, but it causes significant tenderness of acute onset in the carotid bulb area. And it feels like a mass because you're feeling the carotid bulb, and it's quite painful. Moving on to neoplastic disease processes, of course, lymphoma. And the head neck area is the most common location for lymphoma to present to the clinician. This is usually diffuse and bilateral, although not always. Tumors of the submandibular gland, and even tumors of the carotid sheath. We have both carotid body tumors, which are paragangliomas, which arise from the parasympathetic nerves of the carotid body, and vagal schwannomas as well. Metastatic disease to the lateral neck is of significant concern when you're seeing a patient with a lump in the neck, and these are going to be either from a squamous cell carcinoma originating in the oropharynx, such as the tongue base or tonsillar region, as well as from the larynx. Thyroid cancer does have a high incidence of lateral neck metastases. Most of these are papillary carcinoma, with medullary carcinoma also having a high predilection of cervical lymph node metastases, but fortunately being much less common. The supraclavicular area is really just above the clavicle. It's just lateral to the clavicular insertion of the sternocleidomastoid muscle, and there is a cluster of lymph nodes right around here. This is where the thoracic duct brings back lymphatic fluid from much of the body into the venous circulation, and the thoracic duct comes into the internal jugular vein right in the lower part of the neck here. There are several lymph nodes there. Of course, you could have a mass arising from skin and fat. I have, over the years, seen a surprisingly high number of patients referred for an apparent mass in the supraclavicular area simply because they had put on 20 pounds, and the fat can sometimes really bulge out in this area. But lymph nodes in this area are of special concern in the head neck area because these lymph nodes are very different from the other lymph nodes in the head and neck because they receive drainage from other parts of the body. And head and neck cancers, generally speaking, do not spread to the supraclavicular lymph nodes, at least early in the disease process. So a patient presenting with an enlarged lymph node to the supraclavicular, in the supraclavicular area, you have to think about disease under the clavicles. On the right side, the lymph nodes receive drainage from both the lung and the esophagus, and on the left side, where Virchow described a lymph node in this area that was enlarged in a patient with gastric cancer, much of the body can drain to this area. So developing your differential diagnosis is actually very different from the remainder of the head and neck area because of the systemic possibilities. In areas where tuberculosis is endemic, lymphadenitis in the supraclavicular area, TB is actually the most common cause rather than tumor. Lymphoma, of course, and then we have metastatic cancers from the lung, the breast, the stomach, which is what Virchow described, and the pelvic organs, both ovarian and testicular cancer. I actually have a patient right now who has a non-seminomatous testicular cancer with an isolated supraclavicular metastasis. In the posterior neck, again, skin and subcutaneous tumors, lymph nodes exist back there, the muscles of the posterior neck and the spine. So this causes pathology that would be predictable. Sebaceous cysts and epidermal cysts are actually very common in the posterior neck. I think it's a combination of a skin fold, especially in a heavier person, and perspiration that cysts commonly occur in this area. Clinically, those are attached to the skin, so they're fairly easily distinguished from other masses. Lipomas are also very common in the back of the neck, as well as the back in general. Enlarged lymph nodes from inflammatory causes, acne on the scalp is common, nasopharyngitis, and infectious mononucleosis. Of course, lymphoma. Metastatic cancer to the posterior neck is certainly less common. In the case of the throat, the nasopharynx can metastasize to the posterior neck. And then you have skin cancers, both squamous cell and melanoma, that will metastasize to the posterior neck lymph nodes. As I mentioned at the beginning, we had a very timely release of clinical practice guidelines from our academy. Just 2 months ago, they released this paper, which I believe is included in your handout. These guidelines were specifically developed to help primary care physicians approach a patient with a neck mass And the purpose of this is really to avoid delays in diagnosis. Unfortunately, even today with all of the technology that we have, there is, in many cases of head and neck cancer, a significant delay from the time of presentation with a neck mass to the point of diagnosis. And so these guidelines are intended to help you determine which neck masses are concerning and which ones are not. So one of the recommendations of these guidelines in an effort to avoid delays in diagnosis is to end the clinical practice that every patient who has a lump in the neck should get a trial of an antibiotic at the start of their evaluation. They do not recommend that. If there are no signs or symptoms of other associated infectious processes such as tonsillitis, acne, nasopharyngitis, infectious mononucleosis, antibiotics should not be prescribed. They basically defined, and this was through evaluation of the literature and looking at what historical factors are associated with a greater probability of cancer, as well as what physical examination findings are associated with cancer, so that you can identify the higher risk patient. For history, a clear lack of an infectious etiology or a mass that's been present for more than 2 weeks. This does bring up the issue of the patient who just discovered this morning the mass that's been there for 6 months. If the patient really can't clearly tell you when the mass developed, you should presume that it's been there for more than 2 weeks. On physical examination, a mass that's more than 1.5 centimeters, firm, non-tender, fixed, certainly with ulceration of the overlying skin, those would be concerning physical features that would make you want to work this up further. I mentioned the cystic neck mass here because cystic masses in the neck, one would typically think are going to be benign, but this is not always the case. It certainly is in children, but if we look at patients over the age of 40, most cystic masses are going to be malignant. And so you should not assume just because a CT shows a cystic mass in the neck that this is necessarily a benign process. Okay, so we've decided based on history or physical examination that you have a patient who has a suspicious mass. What do you do next? Well, either perform yourself or refer for examination the mucosal surfaces that are at risk for having a malignancy. And this includes the tongue base, the hypopharynx, and the larynx. Following examination, the next step is going to be an FNA biopsy in most cases. We want to avoid open biopsies for the vast majority of patients with a neck mass for 2 reasons. First, they're generally not necessary. FNA has a very high sensitivity and specificity in the evaluation of a neck mass. And secondly, open biopsy can seed the neck as well as the overlying skin with cancer when it's performed, so we want to avoid that. Imaging is strongly recommended in the guidelines in most cases of neck mass present more than 2 weeks, always with contrast. If you order a CT without contrast, you've exposed the patient to the same amount of radiation, but with much less clinical information returned. MRI is definitely a reasonable alternative if the patient has concerns about radiation exposure or contrast allergy. I apologize for this next slide. This is straight out of the clinical practice guidelines in your handout, but if you start to break this down a little bit, it's really not that complicated, and it really just summarizes what we've just talked about. The patient is presenting to you with a neck mass. Do they have signs of infection? If they do, you go down over here and give them antibiotics. Make sure you see them back. This is very important to make sure that the mass goes away. I have over the years, and I can't explain it, I think it's a psychological phenomena, because I have seen countless patients with head and neck cancer who would absolutely swear that their mass has gone away or gotten smaller. And so you examine them, and of course it's still there. It's probably bigger than it was before, but the patient often thinks that it's better, so you really have to have them come back for a follow-up after you give them antibiotics. If they don't have signs and symptoms of infection, no antibiotics at all. We move down this arm here. We talked about features on history and physical examination, which would lead you to be concerned. If you have concern, they emphasize the importance of telling the patient that you have concern. You know, the old days of the physician just saying, I'm going to order some tests and we'll see you back. We don't do that anymore because the patient may not understand the degree of concern that you have. So you have to alert them to that. Go on and do that mucosal examination. We talked about most likely we're going to be getting an imaging study, either a CT or an MRI. Most likely we're going to be doing an FNA biopsy. And most of the time we have a diagnosis as a result of one of those tests, and we're going to move into specific management based on the results of the test. However, cystic masses sometimes can elude diagnosis even with FNA biopsy because most of the mass is either necrotic debris or proteinaceous material, and so an FNA sometimes yields a non-diagnostic result. We cannot stop there just because the pathologist says that they don't identify any malignant cells. In those patients, especially if we are suspicious, we have an adult who's 40 or 50 years old with a cystic neck mass, we're going to go on and most likely at that point do an operative endoscopy, which means a trip to the operating room for laryngoscopy, cervical esophagoscopy. We're going to perform targeted biopsies of at-risk tissues that may include a ipsilateral tonsillectomy, tongue-based biopsy, even a lingual tonsillectomy to look for the primary tumor, and then that will generally yield the diagnosis. In the very rare event that none of this provides a diagnosis, we may have, at that point, have to remove the lymph node for diagnostic purposes. Changing gears to at least my way of thinking, the more interesting part of this talk is bringing to you information about human papillomavirus. I'm sure everyone here is aware of HPV and its association with cervical cancer. But in the head neck area, HPV in the last 20 years has taken on tremendous significance because it turns out it also causes throat cancer. And it's the same HPV subtypes that cause cervical cancer, so it's really, it shouldn't be shocking news, but it is definitely significant in the head neck area. This was a very interesting study that was published several years ago where Gillison and colleagues looked at asymptomatic, randomly selected American adults, men and women. And they simply had them rinse their mouth and spit, and they looked for human papillomavirus. And what they found is that 7% of the American adult population has HPV in their mouth. It is significantly more common in men than women, and for reasons not fully understood. And really concerning is that 1% of Americans are walking around with HPV-16 in their mouth. So this means there's a lot of people at risk of developing throat cancer from the HPV. HPV causes throat cancer specifically in the oropharynx. It does not cause oral tongue or laryngeal cancer, and where it essentially infects the tissues deep within the tonsillar crypts. Both the palatine tonsils, which are the tonsils you see in the soft palate, as well as the lingual tonsil. In case people are not familiar, there is tonsillar tissue on the backside of the tongue. It is called the lingual tonsil. And the HPV virus, for some reason, has the ability to infect cells within the tonsillar crypts, often deep within the crypts. So these cancers often are less easily seen on direct visual examination because it may be a very small tumor deep within the tonsil. HPV infection in this study was found to be associated with other measures of sexual activity and, interestingly, also tobacco use. And tobacco use was an independent predictor of HPV presence, again, for reasons that are not clear. They concluded that oral HPV infection is predominantly sexually transmitted rather than through casual contact. Another very important finding in some of this recent research, and these were colleagues, McElwain and colleagues at the Medical University of South Carolina, were interested in determining, do patients who have HPV-induced oropharyngeal cancer present with different symptoms than our traditional head and neck cancer patients? And the answer is definitively yes. In their study, only 18% of patients who had HPV-induced oropharyngeal cancer actually had a sore throat. Over 50% of patients with smoking-induced oropharyngeal cancer have pain or in their throat or pain when they swallow. So this is a significant departure from that. The vast majority of HPV-positive oropharyngeal cancers will present with nothing else other than a neck mass. So when you have an adult with a lump in their neck, oropharyngeal cancer is now something that you have to be definitely concerned about. There have been a number of studies that have, in the cancer literature, that have looked at the behavior of HPV-induced oropharyngeal cancers compared to smoking-induced oropharyngeal cancers, as well as the changing incidence of HPV-induced throat cancer over the last 30 years. In this study, this was a multi-institutional study where they looked at 271 oropharyngeal tumors retrospectively going back to the early 1980s to the present. And what they found is that over this period of time, there was a more than fourfold increase in the incidence of HPV-induced cancer in the early 2000s compared to the 1980s. Almost 3/4 of all oropharyngeal cancer today is HPV-induced versus only 17% in the 1980s. And I can tell you, doing my residency in the 1990s, we weren't even talking about this yet. But clearly it was there, but it really wasn't being looked at. So this was a retrospective analysis. 90% of HPV-induced oropharyngeal cancer is due to HPV-16, and then a smattering of other high-risk HPVs. What's also interesting is in their study that HPV-positive oropharyngeal cancer patients are much more likely to be male, white, and younger than HPV-negative oropharyngeal cancer patients. Also of significance to us in treating this cancer is that the overall survival for cancers that are stage matched to smoking-induced cancer, the risk of dying of HPV-induced throat cancer is substantially less than if your cancer was caused by smoking, about a 70% reduced likelihood of mortality. A couple graphs on the right side just to show you, but you can see that the incidence here, these lines here of HPV-induced oropharyngeal cancer are going up and going up very, very sharply. This is HPV-induced cervical cancer over here, going down. And HPV-positive oropharyngeal cancer is expected to constitute a majority of all head and neck cancer in the United States sometime in the next 20 years. HPV-positive oropharyngeal cancer is expected to surpass HPV-positive cervical cancer literally in the next couple of years. Okay, so we've talked about how to approach a patient with a lump somewhere in the head and neck region. We'll go through a couple of cases and then I'll take questions. So the first case is a 56-year-old female who presents with a lump in her cheek. She says it's been present for about a year, it's growing very slowly, and she has no history of skin cancer. We get an MRI which shows this very bright lesion on T2 within the right parotid gland. It's in the superficial part of the gland. It has a partially lobulated, septated appearance. It enhances very mildly with contrast. This is a classic pleomorphic adenoma. She underwent a superficial parotidectomy. It was indeed a pleomorphic adenoma. Second case is a 70-year-old female who comes into the office with a lump under the left side of her chin. She says that really the only thing that bothers her is she feels a pulling sensation when she swallows. And when she swallows in the office, you can see the lump go up and down. It doesn't hurt. The only deceptive thing about this case is she's 70. But otherwise, this is a fairly classic presentation. 2.8 centimeter mass, you can see it right here. It has a very cystic appearance. It's really at the junction of the hyoid and laryngeal cartilages. And she underwent a cyst trunk procedure, which is removal of the thyroglossal duct cyst. with an uneventful recovery. Our third case is a 72-year-old male who presented with a lump, 2-month history of a lump in his upper neck. And he's a non-smoker. Physical examination reveals this mass, which is originating from the base of tongue. This is the vallecula up here, and you can see some tongue over here. The mass was actually fairly exophytic. Imaging showed some enlarged lymph nodes in his neck corresponding to what he felt. So he presented with this. You can see there's some hypoattenuation centrally, suggestive of central necrosis. And you can see just how close these lymph nodes are to the base of tongue. Ultrasound-guided FNA biopsy revealed metastatic squamous cell carcinoma. He was treated with a transoral laser resection of the tongue-based mass with negative margins. He had a concurrent functional neck dissection. 2 out of 28 nodes were positive. The tumor was P16 positive. So P16 is simply a marker that pathologists use as a surrogate for HPV so that they don't have to do in situ hybridization. And it's an indicator for high-risk HPV. He then had radiation therapy and is doing well, actually now at, I think, 9 months post-operative with normal swallowing and no evidence of disease. The last patient that I'll present is a 54-year-old male who presented about 7 months following excision of a melanoma from the right posterior scalp. And he had a PET scan performed by his oncologist that revealed this metabolically active lymph node in the posterolateral neck on the ipsilateral side to his melanoma. Interestingly, he also had an ipsilateral thyroid nodule. A thyroid nodule FNA revealed the indeterminate follicular lesion pathology, but FNA of the lymph node was consistent with metastatic melanoma. He underwent a posterolateral neck dissection and concurrent right hemithyroidectomy. The lymph node, unfortunately, was under the spinal accessory nerve, which made excision challenging, but the nerve was preserved. It was the only lymph node involved out of 41 removed. It was 3.2 centimeters, but there was no extracapsular spread, and the thyroid nodule was benign. So, in summary, in evaluating a patient with a neck mass, we want to develop an anatomically based differential diagnosis with consideration for the patient's age. We want to determine the risk of malignancy based on the history elements. Again, lack of previous infection, something present for more than 2 weeks, a mass which is firm, more than 1.5 centimeters, fixed if there's ulceration. Workup with examining the relevant mucosal surfaces, imaging and FNA biopsy. We want to avoid open biopsies in these patients. Keep in mind now the rising incidence of HPV in our patients, and that patients with HPV-induced oropharyngeal cancer are likely to be non-smokers. They are going to be younger. They're more likely to be white and male, and that a neck mass is probably going to be their only manifestation. And also remember that cystic neck masses in adults are frequently malignant. Thank you.
Thank you, Dr. Weiner. Do you have any questions from the audience?
We all work with university-age students, and we have very difficult trying to get Gardasil vaccine, to accept that, but we push it all the time.
Yes.
In the male students, what kind of timeline are you seeing from probable exposure at this age or younger until we see disease?
So I understand your question is, what's the latency between exposure to HPV and development of cancer? It's a good question. I haven't seen any literature that answers that, but presumably there may be a fairly long period of latency. I've certainly seen patients who present with HPV-induced cancer who are widowed or widowers and haven't had sexual contact, sometimes in a very, very long time. So it probably can sit dormant in those tonsillar crypts for a very, very long time.
I work in the prison system, and I have an 18-year-old that I'm dealing with. He has a mandibular, it's like just on his mandibular area going down posterior. He's got like a firm mass. Treated him with an antibiotic. He's back again, and he says it's giving him a headache. It's really difficult to get them to send them out, just for whatever, reasons. They just don't want to send them out. And I'm wondering, I'm doing an X-ray of the mandible, but I'm wondering if maybe I should try to push for a CT or something.
Well, that area that you're describing, which is, the question is essentially a differential diagnosis for an 18-year-old male who's got a firm mass around the angle of the mandible, kind of the back area. That area is chock full of anatomy because you have the tail of the parotid gland there, you have the backside of the submandibular gland, you have cervical lymph nodes there, and if we just look at all comers, 18-year-old with a firm, I don't remember if you said it was tender or not, but if it, the jugular digastric lymph node is where you're talking about. And this is a lymph node that actually has a name in the head and neck because it is the largest lymph node consistently in the head and neck area, and it can be up to 1.5 centimeters. It is the lymph node that becomes enlarged every time someone has an oropharyngeal infection like tonsillitis or even viral oropharyngeal infection. So it's very, very common to see a young adult or a child with an enlarged lymph node in that area, but if it's more than 1.5 centimeters, most likely you're going to need to get imaging, but of course we'd want to examine those surfaces, and I don't know if you have access to ENT services in the system.
We have to send them out, and so it's convincing a committee that he can go out. So it's like I treated him with antibiotics. Like I said, he's back again. And I'm like, I really want to.
Oh, that would make sense.
Last question.
In pediatrics, we frequently, with someone with a neck mass, we frequently order ultrasounds. Is there any utility to that, or should we just go right to CT or MRI?
Good question. I actually thought about that in preparing this talk. Ultrasound can be extremely useful in evaluating a neck mass, but the problem with ultrasound is that it is extremely operator dependent. The ultrasonographer is going to ultrasound the clinical region of interest and present those images to the radiologist. The radiologist is sitting in a dark room, often not with the patient, and they simply comment on whatever pictures or images have been provided. And so it's, I do ultrasound in my office, and I can tell you if someone was just showing me pictures without knowing exactly where that was taken, and it can be a very limited value. I personally, I wouldn't use it as a screening tool. Okay, thank you.